And now our attendees are starting to join us. So thank you all for being here for this evening, for this first EFIC webinar in 2023. And today we are joined by 3 amazing speakers. And as indicated in the past, we requested you to watch the presentation of our panelists beforehand in order to prepare your questions that you can ask in the Q&A box below or in the chat. And so we have our panelists, and they will talk about interventional pain management and pain science and knowledge. And thank you all for being here. May I ask you to introduce you? Maybe Cohen, you can start.
Yes, my name is Koen van Baksem. I'm an anesthesiologist, pain specialist working in Belgium, Ziekenhuis Oost-Limburg. I'm also the president of the Flemish Pain Society, active in the WIP, and also associate editor in Pain Practice.
Super. Roland?
I'm a physio and manual therapist and a lecturer in physiotherapy and doing a pain line there as a lecturer, but also doing research and education in pain. What do we know about pain and what are our attitudes about pain? Specifically started in physiotherapy, but we're also doing general healthcare practitioners. And next to that, I'm doing research into working mechanisms of physio and manual therapy. And based on that, I do different paradigms of central pain processing, and if we can intervene them and change them. And I'm doing that from the Vrije Universiteit Amsterdam and Hanse Hogeschool or Hanse University of Applied Sciences in Groningen, where I live.
Super. And Peter?
I'm Peter Statz. I am from the United States of America. I am a pain physician, anesthesiologist. I am currently chief medical officer of the largest pain practice in the United States, as well as chief medical officer of a company working in vagus nerve stimulation. I'm also president of the World Institute of Pain, where I've been very active for the last 30 or so years.
Fantastic. And once again, thank you all for being here. And I don't know if you know each other, by the way.
Not well. I know some of you guys.
Yeah.
Super.
New faces for me.
And I just want to say to the attendees that actually the chat is not available. It's only the Q&A. So just type your question and we will answer it directly. And I will have maybe a first question for you, Colin. And because in your presentation, you describe the principle of the radiofrequency and understanding the mechanism. And I was wondering in which context the radiofrequency treatment would be used.
Well, the most frequent use is for spinal pain, treating spinal pain, for facet joint pain, cervical and the lumbar region. But you also have, for example, patients with trigeminal neuralgia. You can have a radiofrequency treatment of the ganglion of Gasser. So plexus celiac. So you have quite a wide range of options of indications. You can use radiofrequency.
Super. Yeah, well, our attendees say that we are loud and clear in the UK. So thank you for that. And so thank you, Colin. Our question are coming. Super. I have one question for Peter. Can any patient receive an intrathecal drug delivery?
Well, I don't know about any patient, but many of the complex patients with complex pain problems could benefit from this. Typically, particularly in the United States, I would say the patients who get intrathecal drug delivery are patients with cancer with a expected life expectancy of more than 3 months, severe chronic spinal pain, radicular pain, neuropathic pain, all of those would be considered good indications. Some of the areas that are less positive that I don't recommend it for are things like fibromyalgia or some of those diffuse body pains without a clear etiology. So intrathecal therapy used to be actually a little bit earlier in the algorithm. In the US, we typically try to, we think about this in people who have failed many of the other conservative therapies. Using the baseball metaphor, with intrathecal therapy, we can get, a second base or a triple many times, but we rarely get a home run completely pain gone. Where we can do that with radio frequency, we can do that with spinal cord stimulation, with peripheral nerve stimulation. So intrathecal therapy requires more management and is a little bit more complicated. So it's typically end of the road types of therapy.
Okay, because actually I have a doctorate in neuroscience, and in my PhD, I use osmotic mini pumps in rats. And that's why I was wondering how often would the device need to be changed, or how long this device can stay in the body before being changed?
Yeah, for the most part, it's about 10 or 11 years that these pumps have to be replaced. And that's based on the battery life of the device. There's certainly complications that can occur with a catheter kinking off or developing a break in the catheter system. But I typically think of about 10 or 11 years.
Oh, it's better than in rats then. So
yeah.
Fantastic. Thank you, Peter. And sorry, Roland, your presentation were really more focused on really the nociception and pain modulation. So it was what I would call maybe a bit more fundamental, but it's always really good to know the principle of the neuroscience and the pathway behind the use of any kind of pharmacological product, actually, and also for the radio frequency, and actually where to I guess to target the needle. So that is great as well. And question which asks you, Roland, how would a multidisciplinary approach facilitate the switch from an inhibitory to a facilitatory responses? It's a good question, apparently.
Yeah, the question seems to be quite easy, but the answer is quite complex, I guess. But in the end, I think that is some kind of the holy grail, switching it to an inhibitory system. But to do that without using exogenic chemicals or other forms of exogenics, but with endogenous modulation, we need to change how the patient lives his life. We need to take into account all the multifactorial variables that are out there. And that's the thing we try to do with multidisciplinary approaches. So we look into lifestyle, we look into movement, we look into cognitions, we look into psychosocial factors, anxieties, fear avoidance, and all these things all together. But it's not doable, and I guess will never ever be doable, to directly measure if we are switching it off. The only thing we can do is, if we would isolate one of them, we can check, has it the potential to switch it a bit off or influence it? And then what we see a bit now in multidisciplinary research is that they do NS1 studies to see if they're in the timeline of the patient, they will feel better. And a possibility is to check these endogenous systems, even though I have to say it's, you don't really measure it. It's a paradigm, right? So you can't measure nociception in humans. You can only ask how they feel, or you can use a bit of tricks like conditioned pain modulation, offset analgesia, and things like temporal summation, and use that as a proxy to measure it. And we do see beautiful things there, beautiful associations with lifestyle and psychosocial factors. So it makes sense to make them better, but we don't know on who it will work, how it will work, and all those things combined. It's difficult.
Yes, there's a lot of variability between individuals, right?
Even in healthy, also study on healthy people, how these mechanisms work. And weirdly enough, at least for me, it was really weird. I saw that they had facilitatory systems as well when I started on students. And that seems to have a relationship with how they live. And here in Groningen, we have the most pups per person in town, and they don't have an end time. So we thought it was based on sleep and alcohol. And it seems that that's indeed the case. Lifestyle factors like sleep and alcohol and anxiety for exams and things like that. So we now do it in non-student groups as well. So it's really complex, I guess.
Yes. I don't know, Cohen, you seem like you wanted to respond or ask a question, or?
No, I just was laughing with the lifestyle behavior.
Yes, in student way, not the best lifestyle. And I actually received a question for all of you, which is, do any of you know about TMS and anyone use it for chronic pain like FM or neuropathic pains of different neurological disorders? It's a long question. If not, as I have used it over 5 years, anyone is interested to join me work on application for the neuromodulation of the above mentioned.
Well, look, I'll chime in first, but I'll turn it over to my esteemed colleagues who have more experience in electrophysiology than I. I think of the body as an electrochemical organ. And I say it in that order, an electrochemical organ. We're used to using drugs, we're used to blocking nerves, but I think it's important to stop and think about the electrical basis of how our body functions. And electricity is really very important and underappreciated for how this can modulate pain as well as other disorders. Much of my research more recently has been on modulation of the inflammatory pathways using electrical stimulation of the vagus nerve. And it is incredibly powerful and incredibly important. Less work being done on TMS, but I do think it's a very important avenue to consider for modulation of psychiatric disorders, movement disorders, painful disorders as well. And we tend to spend more time thinking about drugs and nerve blocks and therapy, but we should be integrating the concept of using electricity in different disorders. You mentioned fibromyalgia or FM. I assume that's what you were asking about. There is data on fibromyalgia, probably by modulating TNF-alpha and other inflammatory mediators. That's been shown in both vagus nerve stimulation and TMS, and I think it's a very important avenue to consider, but also stop and think about the why of why you're doing this. And I think much of this is modulation of inflammation as well as modulation of specific neurotransmitters.
I don't have any experience with it, but I know there's a lot of literature. For example, chronic pain patients with radicular pain, radiculopathy. There have been some tests with TMS who were positive. So apparently it's an open route to go. Yeah, but we don't have much experience in Belgium, for example. Mm-hmm.
And otherwise, I have another. Well, I have a lot of questions actually, so it's.
Peter,
I
can I ask you a question?
Sorry,
Peter. Just because of there's a lot of debate going on with chronic opioids for not malignant pain. Does it change in any way the attitude towards intrathecal pumps or intrathecal morphine?
Yeah, so I would say early on, we used the criteria of failure of systemic opioids for consideration of intrathecal pumps. That was the criteria that was used. Another criteria that we used was once you hit 200 milligrams of oral morphine equivalent a day. And we used that criteria in the big cancer pain trial that I was the co-PI on in cancer patients, where we randomized patients to receive either maximum medical care or continued systemic opioids. And in that trial, we showed improvement in pain control, improvement in toxicity, and improvement in life expectancy in the group that got randomized to receive intrathecal therapy. That was a long-winded answer, but just to say, I don't think we use that at all anymore. I think that patients who are on very high doses of opioids don't tend to do particularly well with intrathecal therapy. And it's important that we do opioid rotations much earlier. We considering converting to intrathecal therapy at a much lower dose. We also know, interestingly enough, that patients on high dose opioids don't do as well with other types of therapies, like spinal cord stimulation. If you were to take a look at patients who had been on high dose opioid therapy before getting a stimulator versus low dose opioid therapy, the outcomes are significantly better in those on lower doses of opioid therapy. So when we also marry this to the opioid epidemic that we have going on in the United States with the toxicity and morbidity of opioids, the US is moving much more towards integrating intrathecal therapy and neurostimulation and other types of strategies much earlier in our pain treatment continuum.
Okay, thank you.
Super. And I have another question. Well, I have a lot of questions, as I said. And yes, one for you, Con. Regarding radiofrequency. So the goal is to damage the painful nerve, right? Is there a risk of unwanted spasticity of the nerves and to maybe actually worsen the pain afterward?
Well, that's the discussion. The radiofrequency, conventional radiofrequency, is performed on little, very small fibers. For example, the medial branch fibers of the cervical facets of the lumbar facet joints. So you don't see any problems with it as a complication. If you would do it on for example, spinal nerve, well, there's always a possibility you will initiate even neuropathic pain. So that's why I think worldwide, the application of conventional radiofrequency on the dorsal root ganglion has been abolished. I don't think it's anyone who will still use it, although there's some literature to use it for the cervical level. I think nowadays most of the people use pulse radiofrequency for that. If I look at the evolution from all the literature, then you see more alternatives for the pulse radiofrequency with a higher voltage or a pulse. So there is a tendency to use it in another way, more moving to the conventional radiofrequency. I'm still a little bit scared, to be honest, about the results. I didn't see any complications as yet, but I don't know if it's wise or to do it, to apply it in a clinic without proper basic science performing it. If you look at a lot of research has been done on electron microscope after conventional radiofrequency and also after pulse radiofrequency. And even with pulse radiofrequency, you can see there's little micro trauma you induce to the nerve. So if you, so I would reserve the conventional radiofrequency to the indications we already know. And I don't know if you simply can apply it to any peripheral nerve. That's my opinion. Peter, I don't know your.
You know, I was thinking about the answer to the question very differently. I don't disagree with anything that you said, and I do say that we really do need data to support what we're doing. But I also temper that we also need the best judgment of our doctors to be making the best decision. I moved to using pulse radiofrequency for a lot of my peripheral nerves. I rarely do it on a DRG. I occasionally do, but it's pretty rare. But I moved to using pulse radiofrequency on peripheral nerves because of the safety profile being so much better. But then I get limited here in the United States by the payers. Many of the payers will say, unless you document an 80-degree lesion for 60 seconds, we're not going to pay for it. And it's just protocols that people and barriers that people have been putting up. And in part, we need more science, but in part, the payers need to let physicians do what they think is the right thing. And we sometimes now get held back on what's the right strategy for our patients by payers who just know less than I do. And I can't say that I know everything, but I think I know more than many of the young people who are reviewing my files asking, can I put in a stimulator, or can I, or when I asked to do a stimulator or asked to do a pulse radio frequency or asked to do an RF ablation. Insurance companies sometimes have protocols, and if I don't fit into the protocol, it is a major ordeal to get the patient taken care of. So I have mixed feelings on the whole thing, and I think we should use our best judgment. At the same time, we need to continue our science development.
Okay.
And Roland, does your institute also use radiofrequency or not yet?
Sorry, again?
Does your institute also use radiofrequency or not yet? I'm just curious.
The medical department probably will, but it is interesting to hear you guys discuss this, because my perspective is so totally different since I'm not a medical doctor, and I think that can spark some discussion if we have the time later on, I guess.
It's the goal also of the webinars to put people together and exchange ideas.
Shall I ask it already then?
Yes, of course.
Okay, and it is based upon perspective, and I think that's really interesting. So the way we try to think is from a psychosocial perspective, and if you then think of an adverse event, and medical adverse event means something that a negative biological outcome comes out of it. But from our perspective, if a patient after treatment thinks he is fixed and is passive as doing so, and just gently waits until the doctor fixes him again, it could be called a psychological adverse event as well. And interesting, what I heard are I'll fix you treatments. So I thought is, where is the line in complexity of a patient, or I'm not sure what the English term is, but how much care you should give, how big the problem is, in where you choose a passive treatment where there's a negative adverse event, an external locus of control, and a passive behavior, which has an extreme impact on its pain, versus when you don't do a treatment that is a fix and probably can help them, but you'll keep them in that behavioral part. So where is the line drawn? And I think it's an interesting discussion, because in practice, probably that line is between us as it is now in a Zoom field, but I have no idea where. And I think that's really difficult. Do you guys have any ideas about that? And I have many more questions about that, but where do we draw a line? Where is it smart to do that?
Well, may I make the first stab at it, Koen?
Please.
So when I started in this field, the biopsychosocial approach was completely backwards. The concept that was talked about was don't reinforce bad pain behaviors, because you're just going to, and the way that you reinforce bad pain behaviors is by paying attention to the patient, by doing a procedure, you're reinforcing the bad behaviors, and patients will have a secondary gain. And I have to tell you, I thought that was a very naive view of patient care. And so I started by writing a new theory of pain called Psychological Behaviorism Theory of Pain, published in 1996, with my father, of all people, who was the father of cognitive behavioral psychology. And much of the work that had been going into the, quote, biopsychosocial approach was disjointed and not well thought out. And what we did was we reconceptualized pain as an emotional response. And as such, this is where cognition fits in. That's such, we can figure out where does interventions fit in, where does behavioral approaches fit in. And all of these different aspects need to be integrated into a mechanistic approach, not just throw spaghetti at the wall for bio, spaghetti at the wall for psycho, and spaghetti at the wall for social. But we need a comprehensive approach. And so it's ironic that I am one of the most interventional pain physicians you will ever meet. At the same time, I am a strong believer in psychological behaviorism theory of pain, which I wrote, which is a mechanistic approach for considering where the appropriate interventions come in and where it's appropriate to give the locus of control back to the patient. So again, it's a very, very long-winded answer to, we all need to come together. There's only really one true answer, but, or true, final answer, but there are lots of pieces and we're all right in so many different areas. We just have to figure out where we're each right.
Okay. From my part, I'm a fan of randomized clinical trials with a long duration, because in that way, I think is the most objective way to analyze if a treatment works. And if so, if, for example, if you have patients with a lot of psychological problems, then simply the treatment won't work. So I think that's the proof of the pudding is in the eating. Randomized clinical trials in that case are quite a nice concept. Secondly, in the beginning, we try to converge both the medical treatments and psychological treatments. And to our surprise, that didn't work well. And even after a while, our psychologist said, okay, just do your medical things first, because you really push your patients in a very passive role. So you're quite right on that. But as long as they have a medical treatment, they say, oh, no, I'm not prepared for psychological treatment. So and at this moment, we first do all the medical treatments. After that, we stop everything. We say, okay, that's it. Nothing worked. Your pain isn't improving anymore. And from now on, we will really go for the biopsychosocial behavior. So in our opinion, that works for us the best at this moment. But you're completely right. If you do a medical treatment, you put the patient in a passive role, and that's what you don't want that. But so apparently we have two approaches. And we really divide it into two parts. First, the medical department. If that didn't work, well, we go to the biological and the psychological treatments.
And is that like not a regulation, but a guideline which is developed for the whole institute to first start with the medical, and if it doesn't work, switch?
By error and trial, which just in our institution. Yeah, we all follow this rule, and everyone is content with that.
Okay, super.
And on that base, so if you have, let's say, a normal low back pain, whatever that is, you would not do these kind of interventions, I'd say. But at some moment, you would do it. Is it possible to define that some moment?
I don't understand the question.
Okay, so I'm a physiotherapist and I have a patient with low back pain and it's recurrent for 17 years. At what moment would I send them into medical interventions like radiofrequency or?
Well, if they keep on moving and their pain is under control, there's no need for medical treatment. That's simple. You just do physical therapy. Our goal is not to reduce the pain, pain reduction. Our goal is to try to activate the patients and try to get them better. But the pain reduction as such isn't enough for us. No.
That's a really interesting criteria, because interestingly, no one said it before. It's about control.
Yeah.
So if they are not in control, then we could add a higher intervention.
Yeah, we see a lot of patients in a vicious circle with less movement, more pain, etc. So our goal is to lift them temporarily from that vicious circle, so they get better and they can move more and they can heal themselves. That's our philosophy.
Yeah, so I would answer it a little bit differently. And this is really a wonderful conversation that we're having here. Is I think that the impetus is on the treating provider to make the right diagnosis. And sometimes that diagnosis is muscular instability. Sometimes that diagnosis may be a facet problem. Sometimes that diagnosis may be a compression fracture in the spine. And we can go down the list of different things that cause back pain, and there are literally hundreds of things that cause back pain. We need to make a diagnosis, do effective treatment where we can on the biological aspect, but part of that diagnosis is the psychological comorbidities and the psychological perspective. And I've noted that patients don't get better if you don't fix the underlying biological problem. Similarly, you can't get a patient back to where they're fully functional if they're purely passive. We need to engage our musculature. We need to get people moving again, as you were saying, Colin. And so to me, everything starts with an accurate diagnosis to come up with the right decision tree on what to do next. And that includes the psychological aspects of the patient.
So I'm just going to jump in because I received a question which is related to the discussion. Someone is saying, but there are ample evidence that show combining medical with the CBT, for instance, or simply empowering PT with building knowledge will give us effective treatment. So I don't know if you have any comments on that. Otherwise, I have plenty of other questions.
No, that's quite right. I have a lot of papers on that. But in our clinical practice, we often had discussions with our psychologists, and because of the passive role you push patients in, apparently that doesn't work well with us. So we prefer to do it in a consecutive way rather than parallel. But I understand, I know about those papers, but apparently in our practice, it's less suited.
An interesting take on it, even though it's not hard science, I'd say, but it's Bayesian thinking. You have priors and you can change those priors into you have to move more versus we will fix you. And how strongly those priors are there, the harder it is to change them. So I can understand that if you would do two treatments at the same time, where one is aimed at, well, in contrast of the other, it will not work. On the other side, what I'm thinking, but I don't know how it is here at my home or whatever, is couldn't we enrich the biological intervention by using or choosing words that are less biological and passive and more active, like will temporarily try to reduce pain so you can target the problem and things like that. And so it's what I'm saying is based upon Bayesian thinking, the priors you have, the cognitions have influence on the outcome. And interesting on that, I did a study on all websites of physiotherapy in my country. Luckily, it's not as big as the States, but still 8,000 plus practices, 800 containing information about back pain and neck pain. Less than 79% gave info that said that you should not move or that something is damaged or things like that. Meaning that if the patient comes into the clinic, they have built up a prior with an passive coping, thinking that I will fix them. And as a physio, I don't have real hard interventions, right? It's all endogenous modulation and activating them. We're doing the same on medical websites now, all the university hospitals and things like that. But an interesting thing is that there it happens as well. Couldn't we enrich your treatment by choosing words more carefully? Or is that just a nonsense idea?
No, it's a great idea. In fact, back in the early 1990s, I kind of related. I did an acute pain study where we had patients say positive words or negative words to themselves in response to a painful stimulus. That was the cold pressor test. And those who said positive words, had positive language conditioning, are the words that I used, were able to tolerate, endure, and had changes in their threshold for pain significantly greater than those who thought about nothing, which was significantly better than those who thought of negative or of neutral thoughts as well.
Yeah.
That was picked up by the National Enquirer as thinking about sex relieves chronic pain, say famed researchers at the, or say excited researchers at the famed Johns Hopkins University. So yeah, no, that, and that was based on, when I did the interview with the BBC, they asked me what those positive thoughts are. And I may have slipped and said that thinking about sex could be considered a positive thought. At any rate, your idea of using appropriate language is really important, and it actually goes across multiple different areas. One is mechanisms of placebo effects. A second would be, how does a doctor get the best out of their patients? And that's by creating a very positive bonding relationship and encouragement of their patients to do things and change the emotional state of the patient, in my terminology. But so I think you're right on, and we need to be using language conditioning to try to improve behavior and, by extension, pain.
There was a very nice article last year published where they randomized patients just to tell them, communicate them about the protocol of the imaging of the spine. And they're randomized in two groups. One group, they received just a protocol. They told, okay, you have a facet arthrosis, you have discus bulging, you have a herniated disc, etc. Just told the protocol. In the other group, they said, okay, you have some degeneration, but it's normal for your age. Then they followed them up after some weeks or months, and what they saw that the first group, where they read the protocol with all the degeneration, they saw an increase in pain, they saw a decrease in functionality, and that was quite contrary to the other group, who was more reinforming, and they said that was a decrease in pain and an increase in functionality. So simply the way communication about the imaging can already have an important aspect. So the way you communicate with your patient is very important.
Yeah.
That's great.
With oh, sorry.
No, I love that. I hadn't seen that paper. I'd love to get a copy of that, but that fits in exactly with what I would think would happen there.
Yeah. Papers now come out with placebo and nocebo interventions to check how strong that is, which is really interesting. And to connect it with the lectures of EFIC Academy for those who are wondering if we are not too far. It's probably all about expectancy effects and higher order activation of descending controls. So in the end, and I do think that's perhaps ironic or just beautiful, the whole biopsychosocial model kind of works biological, doesn't it?
Mm-hmm. It
So
does work biological. That's right.
is closed.
Yep.
Placebo and nocebo is quite impressive.
Yeah. Yeah, I love it. But it's really hard in your own communication to do it. We work a lot, studies and lecturing about it, and I see my own patients as well. And sometimes after you saw the patient, you really think, why did I choose those wording? Why did I do it that way? Even though I'm busy with it on a daily basis, it happens everyone, logically. It's really hard.
Is there any training, actually updating communication and updating education in your own field about communication with the patient? Or is something that you would like to see more in your practice?
For physio, we are training the students a lot in it, but to be honest, anecdotal, I see a lot of interns as well that come to my lectures. So they are in the field, they report an extreme high amount of very harsh nocebos, which conflict with the therapy they give. And the most beautiful one is wear and tear. And you must move, which is extremely contradicting. And there's a beautiful study done that those that hear that they have wear and tear as a problem for their osteoarthritis actually have a way less treatment effect as well. Interestingly, in physio, and I think everywhere, we still use loads of nocebo.
Yeah, let me add just a little nuance to that. we've been talking about what the doctor says or what the physiotherapist says to the patient as inducing a placebo or nocebo effect and the positive effect that we can have with the patient. But what's really actually more important than what the doctor says is what the patients are saying to themselves. And when they take that that talk track that the physiotherapist or the physician says to the patient and they repeat it to themselves over and over and over, that's where we get this spiral downwards. And I would like to see one aspect of pain care be that you brought up, I think is a really nice one, is how do we train our patients to talk about pain to themselves? Because that will really, I think, make more difference than what we do on a one-time event.
I agree, and that should be done everywhere where you find info.
Yeah,
if you
but
ask
we don't. But we don't. We here in the U.S., I will say, we send patients on their way. You have 7 minutes to evaluate a patient and send them on their way. And it's important that we stop with the patient and say, stop saying that to yourself. Talk about you can do it. You are able to walk. You are able to function. And I want you to say this to yourself 20 times a day. Until your pain is better, and instruct our patients on how they get better.
Yeah, and empower their movement, indeed. Yep.
So I would like to go back to a few questions that you received meanwhile. Otherwise, the discussion was really interesting. And we received a couple of questions for Peter, actually. So less into communication and more into injection. Someone asked, are you using external epidural and spinal pumps?
Very, very little. In patients with short life expectancy, yes, long-term epidurals or intrathecal catheters are done, but that's really pretty rare. If somebody has a prolonged life expectancy, we put in an implanted pump. Almost 20 years ago now, Marshall, maybe it's actually more than that, Marshall Better did a financial analysis of externalized infusion systems, epidurals, et cetera, versus internalized. And the crossover on cost savings was somewhere between 3 and 6 months. For me, it's really more about the risk profile. If somebody has a long life expectancy and we leave an externalized catheter for long enough, it will get infected. Eventually, it will get infected. You may be lucky and get it for 3 months or 6 months, but we don't do externalized infusion systems for prolonged periods of time.
And the second question we received for you was, where the place is RFA or RF modulation in a range of possibilities, and when to apply them?
It's a really good question. And I honestly don't think we have the answer to that right now. The benefit of an RFA is you're kind of one and done, so to speak. You can place the, do an ablation, lumbar, let's just take lumbar, for example. Patient can potentially go about their way. Now, having said that, you are doing minor damage to the multifidus muscle when you do that. There is some, in concept, some things that we wouldn't want to see happen with an RFA in the multifidus. Another strategy is a peripheral nerve stimulator that's externalized. And I just said you can't put a catheter in for a long period. We can leave externalized stimulator wires in for prolonged periods. And I know it's not available in the US, but in Europe, but in the US, there's a device called the Sprint system, which is made by SPR Therapeutics. And they've demonstrated long-term relief with short-term stimulation. So they implant these electrodes for 60 days, pull out the electrode, and lo and behold, over the next year, patients are still doing well. And so the question is, that's probably a little bit more expensive. It creates more activity that the patient has to take care of this electrode for a period of time. But when you ask a patient, and we did this study, and I think we've published this, but I'd have to go back and check, but would you prefer a neurostimulation approach or that's temporary without a surgical implant? Or would you prefer an RF ablation? Patients preferred the idea of doing a neurostimulation approach versus an RFA. So, that's a very, very long-winded answer again of saying we don't know what the right answer is. I think it's an evolution of the field of which way to go for, low back pain, for example. I don't know which I'd rather have done, an RF or a peripheral nerve stimulator.
Okay, super, thank you. And otherwise, I had a question mostly on my side, because you talked in your presentation about sorry if I may mispronounce, ziconodide.
Yes.
And I was wondering if there were any new knowledge since your presentation.
Yeah, so ziconotide was, I started working on that drug, which is a 25 amino acid peptide isolated originally from the Conus magus snail. And this is a aquatic animal that's, that swims around. It's like a little snail that swims around, and it catches its prey by shooting out an arrow and sucking in these fish that are swimming by. And it basically paralyzes the animal. And a group of scientists looked and found that bound selectively in the dorsal horn of the spinal cord. Long story, carried forward. Gary Bennett, Tony Yaksh did work to identify that this works as an analgesic. And we published back in the early 2000s the results of several randomized controlled trials demonstrating that this is better than placebo, that we could improve pain control for an extended period of time. And now this is becoming a standard care and first-line therapy for patients with low back pain, neuropathic pain in particular. It's part of our treatment algorithms. Many studies have been done over the years to further solidify this. The problem with ziconotide is that it's very expensive, and we need to have a cost-effective strategy if we're going to take care of many, many patients.
Okay, thank you very much.
Sure.
And meanwhile, we receive another question, which I think is for Roland. How many neuromodulation sessions are recommended for chronic low back pain?
I'm not sure if it's my question.
Yeah. It was not precise, so maybe it's a general question.
Yeah, because we do indirect neuromodulation in physio, I guess. And in multidisciplinary and behavioral therapy, but also high velocity thrust manipulation kind of things, you can't really say. You will look at if it's a responder or not, and that can be seen quite early. They will pick it up really fast. They will be enlightened and by that empowered to do more, and then you only have to make that idea stronger. So if this question was aimed at physio, I would say not years and years and years and years, what I see a lot in practice. I'd say you can help them within half a year. But behavioral change takes time, so we have to take that into account. But only if it was a physio question. Could also be
Not sure.
direct neuromodulation, and then probably it's for Kun or Peter.
Could be as well. Maybe you want to respond as well, Gwen?
Well, if you look at neuromodulation as a radio frequency, then you respond or you don't respond. That's that I believe. So you can give it a go, but if you don't, people or they don't respond, or sometimes they have a relapse of pain, or recurrence of pain. That's in our practice. We hope that people at least have 3 months of pain reduction before we consider doing redo radiofrequency treatment. But that's our clinical practice. There's no guidelines on it, I think.
And I was wondering for that, how do you, what is the procedure to target which nerve you're going to target, like for someone with low back pain or someone else? Yeah, how do you map?
Well, there are not so much options for low back pain. More 90-95% of patients is located at the same spot. So L3, L4, L5, because of the you have the most of the charge of the body is on that spot. So most of the people, they have that location for facet joint pain. That's most of the evidence. Apart from that, also the SI joint pain. But there are two main targets for radiofrequency, I think.
Yeah, and just to add a little color to that, we typically provide a local anesthetic block to the area that we are going to ablate in advance at some point in time. Here in the United States, you must do that or you won't get reimbursement for doing an ablation. And we start with making a diagnosis of by history and by physical examination where the patients are experiencing their pain. We then may take them to the X-ray suite and place a little local anesthetic on that medial branch nerve, assess our outcome, and at a later date would potentially come back and ablate that nerve. So it's a three-step process of diagnosis, confirm your diagnosis with local anesthetic block, and then ablate that nerve as best you can. And like Koen says, you want at least 3 months of relief. In the United States, our carriers typically require at least 6 months of relief.
Super. Well, thank you all. And we are getting close to the end of this this webinar. So I wanted to make maybe a last round, and if you have maybe any last comments for attendees or last question for your colleagues.
I'll start and get everybody thinking about things that, I came into this expecting to talk about intrathecal therapy, which is the very end of what we do and the very last ditched approach. But I'm going to start with, emphasizing the importance of going to the other end and make a diagnosis, see your patients, treat them well, empower them, treat them with a positive attitude, make sure the patients understand a positive way of thinking, make a right diagnosis, use your interventions as part of your treatment continuum, don't just say it's either physiotherapy or it's an ablation or something else. Think about it in this continuum and collective approach.
Okay. Well, from my part, I find a shared decision very important because I always talk to patients, give them the different options they have for their treatment. For if we put out a diagnosis, we can say, okay, that are your treatment options, and we do a shared decision always. From my point of view, I find it more and more important.
I cannot agree more with both. But to couple it with the lecture I've did, and I think this is specifically for physios, but I don't want to discriminate for the rest. What we see often is that basic neurophysiology is something that you haven't learned and are not that into, because it seems that it doesn't have any clinical uses because we can't target any of these specific areas since we don't use external interventions. But my reply on that one is, I think for physios and also for everyone that has an intervention, we should always try to understand what mechanism is at play, because we want to enhance it and enrich it. And you only want to use it if it's usable. So in some, we know that the mechanisms are mirrored. So instead of inhibitory, they are facilitatory, and then the exact same treatment will give a very negative result. And you could have known that if you would know a bit about neurophysiology. So my take home is, specifically for the physios, but in the end for everyone, be sure to know a bit about working mechanisms so you're able to optimize it and make the best choices together with your patient.
And apparently communicate properly with them. So thank you all again. And I wish our attendees, so you were 43 tonight, which is a nice number. So you can be proud of you. So I wish you all an happy new year. Good night or day for you, Peter. And see you soon on EFIC.
Okay.
Wonderful to see you all.
Bye.
Bye.